name is Dr. Deborah Beatty-Horn from the University of Texas Center for Obesity Medicine and Metabolic Performance. Thank you for joining me today. I'd like to talk about the principles of diabesity treatment in medical practice. Here are my affiliations, background, and conflicts. And as we look at today's goals, I'd like us to think about what can excellent care in obesity treatment look like. We're going to look at 4 major categories: an overview of the problem, meeting the challenges, including prevalence and cost, treating obesity, including anti-obesity medications, and what that coverage looks like for those medications, and finally, an integrated chronic care model that includes addressing obesity in several ways, not just medically, but also surgically, to help get at diabetes as well. Many people consider obesity a disease of willpower, if they consider it a disease at all. One thing I really want to impress upon you today is that we now understand that not only is it a disease, but we can identify changes in physiological parameters like hormones and neuropeptides that actually affect whether or not you're hungry or satiated in your brain. In the hypothalamus, several of these hormones act to either make you feel full or make you feel hungry. When we try to treat obesity, when an individual tries to go on a dietary intervention, it's interesting that they'll often come back and say, "I feel like I don't have any willpower to manage this disease, Dr. Horn." But what I tell my patients is that it's not your willpower, it's these hormones fighting against you. Several of the hormones downregulate so that we don't feel as full, and one of the hormones upregulates to make us feel more hungry. So it's not your imagination that you actually feel more hungry, it's your hypothalamus. As we think about how to treat obesity and improve the care that our patients receive, we have to identify some of the problems and challenges that face us today. And one of those is the prevalence of the disease, which continues to grow year by year. We can look at things at a national level, but we can also look at things globally. And in this global map of the prevalence of obesity, the cool colors represent low prevalences of obesity, and the warm colors represent higher prevalences of obesity. You can see in the United States that we fall in the top 2 categories: women at a prevalence of greater than 35% in the dark orange color, and men in a prevalence of greater than 30% in the light orange color. So we're definitely not winning the war against the disease yet, but here's our opportunity to try. We know a few things about this prevalence. We know that obesity gets worse with age. You can see this across the graph here, which shows age on the x-axis and prevalence of obesity on the y-axis. In the younger years, that trend goes down to a nadir in adolescence, where the prevalence of obesity is at its lowest. And then every year after that, until we're about 50 or 60, the prevalence of obesity grows. That's the time when we can meet the disease head-on and begin to think about treatment. I mentioned earlier that we were going to look at obesity and also in relationship to diabetes. So we'll start that by looking at the prevalence of the 2 diseases. These are maps provided by the Centers for Disease Control, and they show obesity on the left and diabetes on the right. You can see that obesity's prevalence, the darkest colors match to greater than 25%, and on the right-hand side, diabetes matches to greater than 9%. But what's most interesting is you can see the patterns follow each other. So the most severe areas in the United States of obesity also correlate to the most severe areas of diabetes. And that's how we can see, in this and many other ways, how closely the diseases are tied together and how we can combat them together at one effort. As we think about not just diabetes, but other diseases related to obesity, I'd like to ask you a question. How many comorbidities or associated diseases do you think obesity has? So you can probably pick a couple off the top of your head: diabetes, high blood pressure, arthritis, cardiovascular disease. But if you had to guess how many, just think in your mind what that might be. We've now identified that we are only seeing really the tip of the iceberg associated with obesity and the diseases that are close to it, caused by it, or affected by it. And what we see now is that the number of those diseases is really 236. If that surprises you, you're not alone. With that known knowledge of prevalence, let's take a look a little bit at the cost of obesity in the United States, because I think that's a place where we can really get leverage on ourselves as providers to make a difference and decide to choose to provide excellent care. So just like I asked you how many disease states you thought might be associated with obesity, now I want you to write down or think of in your mind, what do you think obesity cost the United States in 2016? Was it in the millions? Was it in the hundreds of millions? Was it in the billions? Would you be surprised to find out that it was actually $1.42 trillion when we take into account the cost of treating obesity and all its comorbidities? When you think about that number, it can be a little staggering. In fact, it's hard to put into perspective. But you can think of it in this way. It's actually 2 times the cost of the national defense budget. And interestingly enough, it exceeds all but 3 of U.S. states and all but 10 countries' budgets in the world. So it's time for us to have a call for action and really think seriously about how we're going to treat this disease. So let's move on to that. Let's talk about treating the disease of obesity. I think just like diabetes, we want to remember that intensive lifestyle intervention, that focusing on making good choices around nutrition and physical activity should be the start of everyone's care. There's a lot of data around this, and I'm not going to spend time today on that because I want to orient you to a few things that you might not be as familiar with. But always remember that intensive lifestyle intervention is our starting point. As you think about your patient struggling with obesity, I want you to think, what's your goal? What's their goal? What's your goal inside your practice to deliver great care? When I think about that question, I think about 3 answers that we try to move forward in a consistent way at the Center for Obesity Medicine. If we look at those 3 goals that I think of, they're equally appropriate for both obesity and diabetes or diabesity treatment. That's, we want treatment that's successful. We want treatment that's sustainable for the patient in whatever we ask them to do. And we want something that's scalable. We saw the vast prevalence of the disease in the United States, and we have to find a way to treat really 1/3 of the U.S. population that's struggling with obesity. And you can also consider the next 1/3 that's struggling in the overweight range. So 2/3 of America needs some consideration for care. So keep these 3 S's in mind as we move forward into some more specific ideas around treatment beyond the beginning of intensive lifestyle intervention. Let's talk about anti-obesity medications. You may or may not be familiar with them. We have some older anti-obesity medications that are on the market, but recently in the last 4 years, the FDA has also approved 4 new medications. If you're not familiar with the medications, I've listed them for you here. We really have 6 different classes of medications. They each have different mechanisms of action, some of which we understand better than others. Different patients respond differently, just as with any other type of medication. You might have a patient that responds well to an ACE inhibitor and another one that doesn't, and you have to choose a different antihypertensive. Anti-obesity medications are the same way. There are criteria for starting anti-obesity medications for the treatment of obesity, and you can see them here. The FDA recommends that a patient have a BMI greater than 30, that's class 1 obesity, or a BMI greater than or equal to 27 with at least one of those comorbidities that we talked about. And remember, there's 236 of them. We want to consider early intervention in patients that aren't responding to intensive lifestyle change, and early intervention in our bariatric surgery patients who may not be getting the results they wanted from their primary procedure or may be struggling after many years of successful results, thinking about when we can start those anti-obesity medications. We have a short time together, and there's some things around obesity and diabetes that I want you to have an opportunity to understand. So because of that, I'm not going to go over the dosing, side effects, contraindications, or limitations of these 6 classes of medications. But I would encourage you and refer you to the obesity algorithm at www.obesitymedicine.org. There's a very thorough set of slides embedded in the algorithm that will walk you through each of these variables so that you can feel comfortable with them as a provider. But I do want you to understand the efficacy of these medications. This is a study that looked at the placebo-subtracted weight loss, which with each of our new medications. It does not include the older class of medications like phentermine, but it does include some off-label choices that I'm not going to discuss today, and those are the ones that I've X'd out. But you can see in general that the medications that we have for treating obesity today will give the patient about 5 to 10% weight loss, depending on the medication, the dose, and the response of the patient. We know that this 5 to 10% weight loss is successful in lowering risk for many of these 236 comorbidities that we talked about. It can also help patients already with disease states like diabetes, hypertension, abnormal cholesterol, get those diseases under better control and oftentimes reduce or eliminate some of the medications required for those disease states. So although 5 to 10% weight loss might not be the number that your patient has when they first come into your office for help in terms of their goal, it is the first goal that we want to set as clinicians, and then we can help them move forward from those goals. The FDA looks at both total percent of body weight loss, but also how many patients achieved that 5 to 10% weight loss when they decide whether or not to approve a new medication. On this slide, you can see phentermine plus topiramate combined together. That is our trade name medication called Qsymia. You can see lorcaserin, which is Belviq, and you can see liraglutide, which is Saxenda. The blue bars in this graph represent the percentage of patients that achieved at least 5% weight loss and were able to maintain that across 1 year. The yellow bars represent patients who were able to obtain at least 10% of their weight loss. And if you look at this compared to the placebo groups in each of these studies, you would find that that difference in weight loss is about 2 to 3 times greater number of patients reaching 5 to 10% compared to the placebo groups overall, which is a very interesting change compared to what we've seen with lifestyle intervention alone. And that's why it's important to help our patients understand we want them making the great choices around nutrition and physical activity that they can, but they need to interrupt that physiology that's not working right for them, and the medications can help with that and help them get to that 5 to 10% weight loss and sustain it. I've mentioned several times now that obesity is related closely with diabetes. It's interesting. 90% of patients with type 2 diabetes have obesity, and you can see if a patient's weight goes up by just 6 or 7 kilograms, their risk of diabetes increases by 50%, and the reverse is true. If they drop about 5 kilograms of weight, their risk is cut in half. So you can see how obesity as an inflammatory mechanism drives diabetes. And this close relationship is why we should really think about how are we treating diabetes today, and is there a better way to get at solving the diabetes problem by helping patients get their obesity under control. On the right side of this slide, I've listed for you some of the medications that I showed you of our 6 classes and what the reductions in hemoglobin A1C can be on those medications as those patients are losing weight. Interestingly enough, you might recognize that liraglutide is a medication used not only for obesity, but also in a different dose for diabetes, and that's why it's so effective at getting at both of our targets. I think it's interesting to note that we can do a great job of addressing diabetes if we can get someone's weight under better control. You saw the medications that we have so far, which in general put us in about the 5 to 10% weight loss. I want to leave you with some encouraging information about medications, and that is coming very soon down the pipeline are newer medications that put us in the double digits for weight loss around anti-obesity medications, and will also probably help improve their diabetes more significantly than the medications we see now. One of those medications is called semaglutide. It's already recently been released in 2018 for diabetes care, but it will be released at a different dose for obesity in a few years. And at that time, the projections from the initial trials are about a 13.5% weight loss in most patients. I also want to mention that some interesting categories of drugs are in the pipeline for the treatment of obesity, and those include drugs that change metabolism. Currently, to our scientific understanding, the medications that we have in the 6 classes currently do not affect metabolism. And we want to see if we can help those patients whose metabolism is either low to begin with or drops as they try to get their obesity under better control. So look forward to those coming in the horizon. When we think about that close relationship with obesity and diabetes, and the fact that anti-obesity medications can also help get control of someone's diabetes, the Cleveland Clinic and Dr. Bartoboguera have suggested perhaps we need to do a treatment shift in how we focus on diabetes care. He has suggested that, as always, we start with intensive lifestyle intervention, then move the patient on to metformin. If it's still not controlled, think about those diabetes medications that are also weight negative, because many of them can be weight positive, including insulin, and that will only aggravate the underlying problem of obesity and worsen their diabetes. And then if those weight-negative anti-diabetes medications don't get the patient's diabetes under control, we should consider anti-obesity medications. And that's the last blue box that you see here. The one thing that I would add to what Dr. Boguera suggests is that if all of these measures don't work, we still have another parameter we should really think of and should be added to his treatment paradigm. And that is the idea of surgical intervention for the treatment of both diabetes and the underlying obesity. So think about how that might work in your practice and whether you're willing to consider some of that paradigm shift. Now I want to make sure that you understand a little bit about some of the struggles around coverage with anti-obesity medications, because it's not as simple as we would like it to be, and they're not commonly covered in the way that our anti-diabetes or antihypertensive medications are. So to give you an idea of what that looks like, let's look at what diabetes care looks like in the United States. There are about 30 million people struggling with diabetes in the U.S. We have roughly 300,000 physicians writing at least one prescription a month to treat someone's diabetes, and we have about 140,000 physicians writing 10 or more prescriptions per month. And most of those medications are covered for most patients. If we try to get at the underlying cause of the diabetes, the obesity, the scenario is slightly different. We have 3 times as many people in the United States suffering from obesity compared to diabetes. Only about 43,000 individuals are writing at least one prescription of anti-obesity medications a month. Only a very small fraction of practitioners, 2,000, are writing greater than 10 prescriptions of anti-obesity medications per month. And interestingly, only 1 in 5 patients, at best, has medical coverage for these medications. And so, much like we see in bariatric surgery for the treatment of obesity, the medical treatment of obesity, only about 1% of the patients who actually qualify for medication get the medication that they need. If they could, we know that that could help treat their diabetes as well, and likely lower the need for some of their diabetes medications. So let's look a little more closely at the integrated chronic care model. This is a diagram that looks at several different types of interventions done on their own and what the responses are. Along the x-axis are the years of treatment. Along the y-axis is the percent of weight loss from baseline. The top line that you see, or the blue line, is the diabetes prevention program. You can think of this generally as what intensive lifestyle interventions look like. Patients lose between 5 to 10% of their weight, but you can see they struggle to keep it off. The purple line is an example of anti-obesity medication. This one happens to be phentermine, and you can see patients lose about 20% from baseline and then put about half of that back on. The red line is gastric band, and the green line is gastric bypass, and both of these sets of data are from the Swedish obesity study. And you can see a similar curve. Surgery is clearly has a bigger effect on patients, and then we still see that same tendency towards weight regain. So rather than having a patient pick lifestyle intervention or anti-obesity medication or surgery, what if we started doing integrated care and we started layering these pieces on together? Could we get the patient to a more stable weight nadir without the same weight regain? So what could that look like? I have one suggestion from at least one study that tried to layer 2 of the components together. This is a study that looked at liraglutide, one of our anti-obesity medications. On the left, in the white bars, in weeks -14 to 0, is a run-in period in which they asked subjects to lose at least 5% of their weight using intensive lifestyle intervention, basically diet and physical activity. Patients actually lost on average at least 6%, but they had to lose 5% to be run into and randomized into the study. Then, hoping to maintain that weight loss, so we didn't see the weight regain that we usually see, they placed the patients on liraglutide for obesity. The real goal of the study was just to demonstrate the ability to keep that initial intensive lifestyle intervention weight loss off. But what they found was the patients actually lost almost 7% more. What if you looked at this in a different way? What if it was a stronger trajectory in terms of changing that weight status? What if we first did bariatric surgery and then layered anti-obesity medication on? Could we prevent that patient from regaining weight? Those studies are currently underway. I don't have the answers, but we can look forward to them soon. And I think it's a good example of how we can think about putting these 3 different pieces, intensive lifestyle intervention, medication, and surgery together to get the best outcome for our patient. Let's look at one of the most widely known trials, the Stampede trial related to bariatric surgery. I'm not going to get into a lot of the details, but I think there's some things we can glean from a few of the outcomes that will help us understand how to better integrate this care. So these were patients that either had bariatric surgery, gastric sleeve, or gastric bypass with intensive medical therapy, or intensive medical therapy alone. And just as a reminder, this may be a little hard for you to see, so I blew it up for you. The intensive medical therapy was really not obesity therapy. It included no anti-obesity medications. It included intensive traditional diabetes medical therapy. And remember, many of those diabetes medications will actually cause a patient to gain weight and are not weight neutral. So there's a lot of data here, but I only really want you to pick out a few things, and then you can see that the trends are similar across the board. The first is, the goal of the trial was to see how many patients could get their hemoglobin A1C to less than 6%. That was the primary outcome. Not very many patients succeeded in that, but many patients succeeded in improving their hemoglobin A1C by having bariatric surgery. What I want you to look at is the line that's surrounded by the red box. And what you can see is that about 30% of patients with bariatric surgery can get their hemoglobin A1C to less than 6.5%. And interestingly, if you've been watching some of the new recommendations around hemoglobin A1C control, if we loosened that a little to 7%, getting the hemoglobin A1C under 7%, 50% of the patients who had surgery could have met this criteria. And that's a great start. But you'll also notice, if you look a little deeper into the data, that the numbers were better at year 1, about 78% of patients after surgery being in diabetes remission, and by year 5 it had dropped to that 30 to 50%. So my question is, how could we avoid that drop? Could we look at how to best find our great responders to metabolic surgery so that bariatric surgery can be used to treat diabetes? And also, how can we layer in medications to help keep the patients from regaining that weight so that their hemoglobin A1C will stay under better control long term? I think it's interesting that just like the Cleveland Clinic developed a paradigm shift for the treatment of diabetes around medical care, our surgeons have developed a treatment paradigm shift around the surgical care of diabetes. And what I want to encourage us to think about on this one is the opposite of what we encouraged before. So in the medical paradigm shift, we talked about the surgery piece was missing. In our surgical treatment care, I think the anti-obesity medication piece is missing. And we really need to think about how we pull all these pieces together for our patients to have their greatest success. So as we think about what can really improve diabetes long term, let's think about how we make that stay in remission for patients. And it may be the combination of all of these therapies together that really work for our patients. Now I just want to think about our patients for a little bit. So what if a patient comes to you and says, Dr. Horn, I need your help. I initially lost 100 pounds with my gastric bypass, but now I've regained 40 of them. My blood sugar was initially under control after surgery, but now it's creeping back up. I'm worried that I'm going to regain all my weight and need to go back on my diabetes medications. I'm watching my nutrition, but I don't get full anymore, and I'm doing regular physical activity. So having heard what the patient has to say, what's the next best step for this patient? Is it revisit the surgical data and the expectations of that with the patient? Remember, this patient has lost 100 pounds. She's regained some of it, but in the common pathway that we would see from the Swedish obesity study, and she's kept off 60 pounds, which is a tremendous amount, well beyond the 10% required for improving her comorbidities. Should we schedule a visit with a dietitian? It's always good to think about revisiting what the nutritional patterns are when we're far out from the initial intervention. Should we initiate anti-obesity medication? New data suggests that, retrospectively at least, initiating anti-obesity medication in surgical patients when they've hit a nadir or started to regain weight can really help them have improved successful results. Should we restart her diabetes medications? All of these answers could be correct, and what we really need to think about is a team approach for the patient. Different areas of specialty will see different areas that can find improvement, and the question is, how do we really put all those areas together to help our patients? So if we think about this, which part of the disease are you recognizing in this patient, depending on whether you're their primary care doctor, their surgeon, their obesity medicine specialist, their nurse practitioner, or their dietitian? And can a team recognize the whole patient in a more effective way if we put all the pieces together and see the patient as a whole? As we consider this integrated care model, take a look at this diagram, which outlines efficacy versus risk for the different options we have for treatment. In the upper left-hand corner are intensive lifestyle interventions, in the bottom right are surgical interventions, and in the middle are anti-obesity medications. What if instead of individualized bubbles of care, we could layer these bubbles on top of each other, offer our patients all of the treatments comprehensively to get them to a better outcome and sustained success? Remember what our original goal was: a successful, sustainable, and scalable model of treatment. Thank you for taking time to listen today. I also want to recognize my colleagues who contributed so much of the work that we do in obesity at the University of Texas. And I also, most importantly, want to thank our patients who let us help them improve their health every day.